This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, a cardiology specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on the echocardiography. Today we're talking about past, present, and future. And with me for this podcast, we have my very illustrious friend, Dr. Nelson Schiller, who's a professor of medicine. He's also founder of the Echo Lab at UCSF and also founder of the Adult Congenital Heart Clinic at UCSF. Nelson, thank you for being here today on the beautiful Saturday afternoon.
Great pleasure. It's beautiful in both places, which is something.
Yeah,
we had a great day. Played a little tennis this morning, but not very well, of course. Got out there.
Nelson has been my mentor. He was my mentor 40 years ago, and here we are 40 years later, and he's still mentoring me.
You know, it seems like, Alan, it seems like yesterday. It really does. I can still, picture us in that reading room, reading them out and talking about good ideas and all the productivity that you brought to the lab. You wrote some of our best papers, so I owe you a great deal.
Well, thank you for that, but it was obviously a team effort. Nelson, I think you had a pretty good team, but how did you actually start in the field of echo? I mean, you started in the 70s, right?
Well, that's a fun story. I didn't know we were going to have fun on this podcast. What happened was, when I was a resident in San Diego with Gene Braunwald's program, which was brief before he went to Boston again, there was a radiologist named George Leopold who had an echo machine, and I was supposed to present a case at a conference. And there was an echo on the case, and I'd never even heard of what this was, an echo. And so it was a mitral stenosis case, and I sort of presented that. And then I remembered back, actually, even before that, to when I was a medical student, there was a wonderful teacher named Jules Constant who wrote a book called Bedside Cardiology and Learning Electrocardiography. All he cared about was learning. In fact, he would never apply for a promotion. So he remained an instructor to his dying day, and which is really hard to do. And but he was a great teacher, and he went to the heart meetings, and he would record every session. He'd put a tape recorder on the floor, and then all year long with the medical students, he'd play the abstracts. And one of them was Harvey Feigenbaum describing pericardial effusion. So we got a patient from Roswell Park Cancer Hospital with a malignant effusion, and we did a midliner ultrasound on that patient and showed the effusion the way Harvey had described it. And that got me interested. And then one day, I'm a cardiac fellow, and I'm in clinic, and one of the salesmen left an echo machine in the hallway, and it was just gathering dust. So I moved it into my clinic. And pretty soon, all the diagnoses that the various professors had written down were wrong. I could see that mitral stenosis was not mitral regurg and aortic stenosis. It was just incredible. My jaw dropped open. Here was like the sixth gun in the West, It was a great equalizer. All of a sudden, I could find things out that nobody else knew. And for years, they joked, "Oh, this looks like a weather front," and I'd present this at CAT conference, and there was great derision. But you knew the minute you used it that it was unbelievable, that this was going to be one of the most important things in the 20th century. And that's what Gene Braunwald said. He said next to cardiac surgery, the invention of the echo was the biggest advance in 20th century cardiology. So I was very lucky to kind of see the truth of that. And now it's the most commonly performed cardiac test there is. So thank you for allowing me to blather on about that. But it was great fun in the beginning because nobody believed you.
Yeah. I know it helped me a lot. When I started in your lab, that was like in 1983, this is where I started learning my cardiology. And it was actually wonderful to be able to listen to the patient with a stethoscope and then corroborate the findings with the echo or correct my findings.
Well, the echo made me love physical exam. And also I would have to acknowledge I got great support from Kanu Chatterjee and from Bill Parmley. They really believed in what I was doing. And Chatterjee particularly was a great friend. I mean, so what I would do would the technicians would take the echo, and that we always had the patient left recumbency and a hole in the mattress. So I'd come in with my stethoscope and I'd see if I could guess what the echo showed. And I discovered that if you really want to listen to a patient, you have to put them in left recumbency. You have to have the window accessible. And most 90% of the time, nobody does that. And so I love a physical exam as well. And I love to teach the students, and nobody knows how to do that anymore. It's become a thing of the past. They order an echo if they hear a murmur.
Yeah, exactly. Not only you're a wonderful cardiologist, Nelson, but also you're married to an incredible wife, smart, and it just happens also to be a mathematician, and helped you a lot, I say, in formulating, a way to measure left ventricular mass, in patients and so forth. And really, you made me kind of at least realize that, size really matters. And it was really, once the 80s started, it was like a 2D echo, and to be able to calculate volume and mass was really incredible. Is this actually something that is you're still very active in quantifying left ventricular volume and mass in patients?
Yeah, it's very frustrating, I have to say, that from the 80s, when you were there, we were doing this routinely. We got the stenographers to do it. It was like pulling teeth at first to get them to measure everything. And we've cut the measurements down to just 4 or 5 things. That's all we look at, one of which is LV mass, which has incredible prognostic value. It also helps sort out when a cardiogram is abnormal. It helps you tell which patient with hypertension you might want to treat more aggressively. There's just so many things about left ventricular mass that are important. And but even more important, and as long as I have this audience here, let me take advantage of one thing where cardiology and the organized echo world have failed miserably, and that is to enforce the addition of blood pressure to every study we do. And if you notice, the echo machines don't have blood pressure on them. They don't have a cuff. You can't put the number on as you're doing the study. You just can't do it. And I have a consulting arrangement with General Electric. I've been at a meeting with many companies over the years, Siemens, Philips, and they just won't do it. They won't do it. They're dumbed down. And I cannot interpret an echo unless I see the blood pressure first. It makes such a difference. If somebody looks like they might have amyloid or an infiltrative cardiomyopathy, and their blood pressure is 150, and the first screen you open up and it's 150, they don't have it. And if they have a blood pressure of 80, you kind of know they do. And so it directs your attention. And I will say something formally here. Before I read an echo, I look at the quantitation. Size matters so much. You couldn't have said it better. The most important number in the heart, next to left ventricular mass, is the end systolic volume index, because that is what we call elastance. The end systolic volume index is the smallest the heart gets at the highest pressure. It's like opposing your finger and your thumb and forefinger. If you've got a very badly arthritic hand, you can't put them together. And a bad heart can't put the thumb and forefinger together. The bad heart can't make itself small while it's generating its maximum pressure, so-called arterial elastance. And that is the corner of the pressure volume loop. And that is the number I look at first, absolutely first, because anything over 29 ml per meter square immediately starts my antenna waving, immediately raises my hackles. And I know that this patient has a problem. From now on, I'm going to look at the echo and the patient's cardiac function entirely differently if the end systolic volume is elevated, because I immediately know what the pressure volume loop looks like, and I know who to pay attention to. It never fails to help. So before I even look at a picture, I look at the blood pressure, I look at the numbers, mainly end systolic volume, index, and the mass, of course, and the other fancy number, which we can cover when we get into Doppler, is the LVOT-VTI. Those are the numbers I need to look at. And I can tell you something about when we get into that, we'll talk about our future research, which is now dealing with arterial resistance. So it's going to be kind of interesting to share that thought with you as well. But look at the numbers first before you read an echo.
A lot of work that you did also, in particularly with diabetics, you use echo to really characterize, disease. I mean, here in the diabetics, and I still remember these incredible, identical twins that had that had completely different heart size. I mean, the one
they were identical twins.
Yeah,
the one was born with diabetes, the other didn't, and their hearts were half the size. The one with diabetes had a tiny little heart, and the other one, and they were otherwise identical twins. That was John Karam's patients. Poor John, unfortunately, passed away recently, but those patients, we have them in a paper. We put them in a paper, didn't we? Wasn't that with Nancy Stans and you and
that patient population was so well characterized,
but the one thing that came out of that work, and it's still hanging out there, waiting for someone to do it. Say, I got to get you back for a sabbatical. Get you to finish these things. But the thing we noticed is that diabetics had small hearts, and they had small, stiff hearts. And now we know as people age, there are two things. As people age, their hearts get smaller. If they're healthy, and which is one of the reasons why, taking up a marathon running, say we didn't have back problems and the like, what would keep us from running marathons or competing with younger people? One would be our heart gets smaller, so that it has to pump harder to put out the same amount of blood. And of course, it gets stiffer. We get grade 1 diastolic dysfunction. We get a higher pressure when it fills. And so you have to go faster, and it's at higher pressure. So you get short of breath right away. You get high pressure in your lungs, and you just can't run fast. So that small heart has been ignored. Nobody's ever written about it. And I see it every single day as we get our population is aging so dramatically. I mean, when did we have 90-year-olds in our practice the way we have now? Everybody's 90 because we follow the guidelines. We treat patients according to the guidelines, and they work. That's the big story. That they actually
I know
work.
that in 1980s, we touched a little bit on diastolic dysfunction, looking at the atrial emptying index that, I think Rich Pop had done some work. How do we look at diastolic dysfunction nowadays?
Well, we started looking at that at the aortic root. We could see right away as people age. And it's interesting. This is kind of a segue to what you were interested in. But the aortic root sits on top of the left atrium, and it's a guide. It's a measure of atrial emptying. When you put the M motor, the aortic root, on the screen, you can look at the various phases of filling and emptying. And as people age, you can say, how old is that person's heart? We have it actually in our research lab. We now have a full research lab, I should say, for the last 10 years. And I read every study that we do in that lab. And the game we play when I read them is we all guess the age of the patient from the echo without knowing it. And if you look at the aortic root, you can tell immediately how old someone is because of the filling pattern. And then that was our entree to diastolic dysfunction, the aortic root. That's how we got started. It was even before 2D or before Doppler. We could tell that the filling was slow, that the atrial contraction was exaggerated as people aged. Now we've revisited that. We've gone back to the beginning. And I have this brilliant woman from Saudi Arabia who is doing artificial intelligence analysis of aortic root motion. And she's already done cluster analysis to show that we definitely can tell how old people are in a normal population just from the aortic root motion. So that's been kind of fun. We just recruited that genius. And
what about the tissue Doppler? You use that much, or the combination?
Oh yeah, of course. We weren't doing that when we were together. We never heard of it. No. Well, actually, were you there when Luisa Munoz was there?
No.
She came after you. Yeah.
Yeah.
We had how about Carl from France? He was there, after you. Well, we had the first tissue Doppler. Honest to God, we had a machine, and he wrote a paper on that, and it was forgotten. Nobody noticed it. And it was all it is wall thumps. It's Doppler of the myocardial tissue. And what you do then is you pick up the motion of the tissue. Now, we weren't going to get into Doppler, but you pick up the motion of the base of the heart using low velocity motion. And it's extremely informative as to how fast things are filling and emptying. And it took us a long time to warm up to it. When we started the Heart and Soul study, for example, in 2000, our first echo machine didn't have Doppler tissue imaging. And then 5 years later, when we did a 5-year follow-up on that 1,000 patients with coronary disease, we did Doppler tissue imaging. And that's how we started. Our early papers were tough to get published because we didn't have Doppler tissue imaging. That it wasn't available in 2000, but shortly thereafter it was. I use it all the time, of course.
Right. So that's.
And I don't know if this is helping patients, though. Right. I mean, to understand what we do, because I think they've first of all become totally used to getting echoes. And in fact, I have some people that want them every 6 months, and I have to tell them, no, that's ridiculous. But they do. They want the echo every 6 months, and I don't know what to tell them. The insurance company won't pay, and but the other day, our lab. Remember, we used to do 10 studies. We thought we were working hard. That was in 1980 when you were there.
Yeah,
83, and now we did 100 studies the other day in our lab. And that doesn't count the peds. It doesn't count the, all the other people doing echo, POCUS, bedside. I mean, there's so many topics we could talk about. Right now, this is something of interest, I think, to your patients. Because of good luck and being on the West Coast, we get access to, a lot of new technology. And one of them is a company in Seattle called Echonos, Nous. It's founded by a Greek engineer, and so he uses Greek words. The machine is called the Cosmos, and this is a tablet, handheld tablet echo machine. And so they gave me one to try out because I'm on the medical board, and I've used it every patient in my clinic, every single patient in my clinic. What we do is we bring the patient into the room, we do an electronic auscultation, and then we do the bedside echo. And then we take them in and take the history and talk to them. Of course, I prepped in advance. I know generally what's wrong with them, but this has just helped us so much. It's cut down the number of visits, the number of repeat echoes. We can check the right atrial pressure. We can check obviously the size of the heart and some of the Doppler things we can measure directly with that. So the POCUS, the point of care ultrasound, is really, to me, a new era. So instead of going into your doctor's office and having them say, "Oh, we're going to order an echo, come back here, 50 miles, and maybe we can schedule it in a month," we can do it right then and there, and we can really focus on the next stage if they need a more advanced study.
Right. Well,
so that's been something new.
Maybe we should get that in Alabama, Nelson. Maybe we could.
I think you would, Alain, you would love it. You would absolutely love it.
Yeah.
Because it would, number one, save an extra visit in many cases, and allow you, and if you have residents and fellows, even if you don't, allow you to focus what you're doing then and there. And in other words, it just saves a tremendous amount of time. And the patients love it, of course. They're sitting there with this little tablet, and you can show them their heart, and it's really easy to do.
Yeah, absolutely.
So I recommend. There are other companies that make them. I'm not, I don't want to make this into an ad. There's I think GE has a V scan, I think they call it. It's worth it. It isn't a luxury.
Right.
And you don't necessarily want the folks, well, I shouldn't say this on a podcast, but let's just say it doesn't belong in everyone's hands.
Right. Who knows,
I'm not going to name whose hands it doesn't belong. I'll let you use your imagination as to whose hands it doesn't belong in. But, I hate to say it, I'm picking up a lot of infiltrative cardiomyopathies. I'm in my clinic. When I'm doc of the week, instead of making ward rounds, I've traded that in for taking a couple times, let's say once a month. I spend a week in the outpatient clinic seeing any new patient that wants to come along.
Yeah.
And that's called doc of the week. So this last week I just finished, I think I saw something like 30 some patients, new patients. And to do this bedside echo on them, and then to get them directed, an awful lot of them don't need a doctor. They're fine.
Right.
They felt the heart skip a beat once, and their doctor sent them to a cardiologist. You've seen that happen, of course.
Yeah.
Or they need clearance for an operation, and there's nothing wrong with them. But about half of them have something, of course.
Right.
And
that's where you can have an impact. Well, Nelson, what about systolic function? Have you gone all 3D? I mean, 3D is supposed to be
now you want me to give away. You want me to give away my research idea? I would say that we should, as soon as possible, turn everything over to 3D. We should do volumetric imaging and let the machine do the measurements rather than tracing them laboriously.
Right.
As wonderful as tracings are, they just don't reproduce that well. And one sonographer is different from another. There are too many variables. But if you have a 3D data set let's take the left atrium. You probably can get the same volume from every window. You probably could get an apical window, subcostal window, and a precordial window. Now we're talking, for those who don't know what I mean, that is where you put the transducer to take a picture of the heart. A 3D image should be the same in every place. And now if we have an automated analysis, we have the chance to achieve what we've never achieved in all the years I've done this, and that is absolute reproducibility. Because right now, somebody measures an atrium, it's 33 ml per meter square, or it's 35. Is that a difference? Well, we know, I don't know if you were part of that paper, but we did a variability study. It was pretty sobering that there was 10 up to 10, 15% variability with nothing changing. And that is a big problem, but 3D can solve that. And 3D with AI, with artificial intelligence, is really going to be the keys to the kingdom. I think that when technicians are taking, I should call them sonographers, of course, when sonographers are taking images, if they are equipped with artificial intelligence on their machine and they do a 3D image, that eventually should be able to tell them, A, that they have the right image, and B, exactly what the volumes are. Not approximately, but exactly. And so when the patient comes back 6 months later and you give an Entresto, or you've given some of the newer medications we're talking about, you can see if you've had an effect. You can see if it's a 5% change, you can say your heart's better. Nowadays, if it's a 5% chance, you don't know. I mean, it could be error measurement. Well,
it's particularly important in cardio-oncology, where these patients are getting adriamycin or Keytruda, and then you want to make sure their LV function remains stable. And these patients
are with the checkpoint inhibitors, it's very hard to tell exactly what's happened. We're doing strain for that. We haven't talked about strain.
Yeah. What about strain? So Nelson, we're doing a bunch of
sorry, I mentioned it.
strain and the global longitudinal strain, and when you let the computer do, sometimes it will do things kind of funny. It doesn't quite line up, and the strain
what we've done is we have 135 normal volunteers. Now, people say, "Well, why are you doing normals?" Well, this has turned out to be a gold mine, and we've done not only strain and DTI and Doppler and 3D and every one of them, but then we exercise them all. And so we have 3D exercise and strain exercise of the atria and the ventricles, right ventricle, right atrium, left atrium. So we've done the whole, I have this magical sonographer for research named Dwight Bibby. And Dwight is, I don't know, he was I think he was All-American basketball or something. And to him, an echo is an athletic event.
Wow.
And he has this incredible data set, which we've now actually allowed commercial people to use. And it's really been, and that's the gateway to artificial intelligence, really, is to have a data set that's that impeccable, which it is. And so, so we do strain. Okay. I am convinced from that experience, which is not universal, that atrial strain, for example, really starts to pick up early stuff. Normally, the strain rate or the percentage, as we express it, for the say the left atrium is about 37, minus 37, and as soon as we get people with AF, even though their atrial volume might be normal, and we have a whole set of patients now with AF, and they're in sinus rhythm, they've been cardioverted, they're doing okay, but their strain rates are much lower as a group. And so that's eye-opening. Also, the right atrium turns out to be abnormal as well, almost always. And again, the strain is the first thing that shows that. So we're excited about atrial strain. We're excited about using deformity, as it were. Now, for the people that don't know what that is, a strain is taking a speckle in the myocardial echo and following that speckle as an exact expression of motion of that part of the heart. It's free from the twist of the heart, which often confounds measurements, but a speckle tracking is the most accurate we can get to actually see the motion of that part of the heart in a given spot. And so we're using the speckle tracking to create this strain rate images. And there are problems. Sometimes it inexplicably goes down. We don't know what that means. And everything else is normal. So it isn't as wonderful as you might think it should be. But when it comes to looking at infiltrative cardiomyopathy and suspecting amyloid and things of that sort, this disease we're now recognizing in older people, it's really quite good. It does a beautiful job of pointing out a very specific pattern. And unfortunately, I've been using it a lot lately for that. Right. So it's valuable. We're still trying to figure out what it means when you exercise someone for coronary disease, for example, and you're getting the strains post-exercise, and I still can't figure out exactly what that.
Right.
That's
well, it's important.
It's difficult.
In cardio-oncology, I mean, it's so sensitive, the strain. That's the first thing to become abnormal, even before, the ejection fraction. And but I find that even in normal, it's not that easy, and we have problem with reproducibility. But I guess if you do it a lot, you get good.
Well, we do a lot for sure. Every research study, and we're now doing a project called Beat AF. It's an NIH sponsored project that our chief Jeff Olgan was awarded by the NIH. And so we're studying patients who've had AF and are now in sinus rhythm, who are considered to be at high risk for AF or are in AF, and these are pretty abnormal studies. I mean, in fact, atrial fib, and I put this in an abstract which got rejected. Couldn't believe it. We think people with atrial fib have a form of atrial HFpEF, that the atrium behaves like it has HFpEF. Yeah. And that's the strain and the volume change and all that. So it's atrial HFpEF.
We have already a problem with LV HFpEF, Nelson.
Yeah. So now I want you to have
treatment. Atrial
HFpEF.
Well, Nelson, we talked about size matters. We talked about characterization of disease. They were diabetics. We talked about LV function, the strain, and also the 3D. What about this AI? I mean, you've been so involved in the last several years with.
Well, I'll give you an example. I'm not going to pretend to understand it as well as I should. It takes me about 10 years to figure things out. I'm still.
You're already 10 years ahead of most people.
Well, fortunately, what we do is complex. I guess it's fortunate because we keep our jobs. But I'll give you an example. The late Rakesh Mishra, one of our most brilliant fellows who tragically we lost recently. Before he died, he completed a project. He took a heart failure index that we had created with the heart and soul data. Now, this is 1,000 patients with coronary disease that we followed now for over 10 years. And we really did everything we could to them. I mean, they've had every single kind of test you could conjure up. Now, what we had done is we showed that a heart failure index was a very powerful predictor using many echo parameters. But the one thing that didn't work the way we expected in this group was end-systolic volume index, which was my favorite number.
Yeah.
And it just didn't quite make statistical significance until Rakesh came along and he applied a cluster analysis, AI, artificial intelligence to that. And lo and behold, the end-systolic volume index clustered the most powerful clustering. So it was able to analyze many more factors that we had collected than we could possibly handle with ordinary statistics, and it really delivered the goods.
Was that the Spearman analysis that he did on the to get these other kind of factors or data right. that you didn't know were?
Well, they showed two. They were there as well, but the end-systolic volume came out better than anything else, and yet it had failed in the ordinary analysis that we were using. Multivariate analysis, so-called multivariate analysis.
Right. Yeah, pretty amazing to be able to predict, who's going to require hospitalization for heart failure just on the echo data. I mean, it's really powerful.
Can be done. Well, it gives me a chance to say another little philosophic thing. We have outgrown our root supply. In other words, I don't know how many days a week you read echoes in the lab, or how many you have to read. Yeah, you have to read a lot. It's a lot of work, and there's a lot of data there. In fact, it's too much. We are creating data faster than our brains can absorb it, and we need help. We need something to do this automatically. And again, that is where AI is going to come in. AI is going to help us, because what's going to happen is when the sonographers take the images, not only will they do 3D images whenever possible, but the AI will guide them into saying, you're through with the study. You can stop now. There's nothing wrong. Don't waste any more time. And the reader is going to have that help as well. So we can handle this increased volume and have more accuracy. It'll point out when things aren't right away, and the study will expand appropriately. Not the same study for everybody, but a more appropriately focused study.
And so reproducibility.
Yeah. So right now I'm working with some AI algorithms for diastolic function. I can't say which company because I've signed something, but it actually looks at an echo. We just published this, by the way, on we took 3 readers. It just came out yesterday, in fact, in Echocardiography, a Nanda's journal, and we took 3 readers and asked them, all board certified, asked them to judge diastolic function on a set of 50 patients from my practice. I sent them over. I would get them in my office and I'd say, would you mind if we did a quick echo? So Dwight, my stenographer, did his echoes on these 50 people, gave them to the 3 readers, and their readings were pretty variable.
Right.
They weren't terrible, but they weren't that good.
Mm-hmm.
Now we have this AI algorithm, one of the companies has developed, and we're going to put the same 50 patients through that and see if it's more reproducible. So hopefully, I want to open the era before I exit here, from the ravages of age. I'd like to leave the door open to AI application to make life easier for people, so that they get an accurate number they can rely on every time, and they can handle a myriad of data without necessarily having to try to put it together themselves. Yeah. So that's where I think the future is so bright for this kind of thing. And by the way, did you ever worry that MRI was going to take the place of echo?
Well, yes, in a way, because I mean, look, for example, and we're going to talk a little bit about this, but look at LV mass. And look at the mitral regurgitation or AI when you want to calculate regurgitant volume and so forth. I mean, people are going to MRI.
Yeah, but let me tell you something. I had an MRI the other day for my back, and I never want to have another one again. Furthermore,
are you claustrophobic?
Well, I wasn't claustrophobic, but 15 minutes is a long time not to move.
Yeah.
And to hear all these noises and having air blown in your face, I found it very unpleasant. And I couldn't get scheduled for months.
Yeah.
And I have pull. So I don't think MRI is any threat.
Right.
to what we do. If we make echo accurate,
right,
the sky's the limit. MRI won't.
3D is probably the way to go, because you sample the whole heart. The problem with MRI, you get all the slices of the heart and you get the whole heart, but that's when you can get it with the.
Well, it's also, again, I'm going to skate on thin ice here and probably get into trouble. But again, it depends who's interpreting the MRI.
Yeah.
And like POCUS, like point of care ultrasound, it's not always the people you would prefer.
Right. Yes, not easy. Well, listen, we can't be on this podcast without talking about Doppler echocardiography. And
sure.
And when I started in the 80s, of course, Liv Hatley had made Doppler so useful, particularly for aortic valve stenosis. And nowadays, I mean, most people don't even cross the aortic valve with a pigtail catheter. They ask, what is the Doppler, showing? But it can be a little challenging in the valvular regurgitation. And maybe we could talk about that. Maybe we could kind of concentrate on first the mitral valve and then the aortic valve. The color Doppler was just starting in the 80s. So that was really exciting. We could see the jet, we could see the regurgitated lesion, but there's so much variation. How do you assess mitral regurgitation by Doppler?
Well, I could start with a paper that we wrote years ago with Lisa Thomas. I think she was after your time too. She's now in Australia running an echo lab somewhere. I shouldn't say somewhere, I should know exactly where. But Lisa did this really, and Julian Hoffman, I don't know if you remember Julian, he was a pediatric cardiologist, and he recently passed away in his late 90s.
Wow.
I had the honor of being his physician. But Julian helped us with this analysis. And so we came up with a mitral regurg index of using 6 different parameters. It had to do with jet entrainment. It had to do with the density of the MR jet. It had to do So we took everything we could think of that went into judging the severity of mitral regurgitation. But that doesn't help anyone to have to dig out a paper I wrote. But what I would say in general is that mitral regurgitation is a really almost violent problem in a way. And most of the time it's mild. Most of the time it doesn't mean much. But when it's significant, it creates blood flow backwards from where it ought to be going at the wrong time. I mean, it's like, I don't know what to say. I can't think of an analogy in life, but you have blood flow going backward when it should be going forward. You have a V wave. You're invading, so you're losing half of your blood flow if it's severe enough, if the valve is incompetent. So there's so many different things that happen when that happens. So many things you can see. They're all in echo, of course. You can see, starting with forward cardiac output, the VTI, the stroke volume at the left ventricle, diminishes. It must diminish. The size of the left ventricle increases. It must. The size of the left atrium increases. It must. The blood flow, of course, signals are all completely wrong. You get a dense jet where there should be zero jet. You get elevation of pulmonary pressure where you should have normal pulmonary pressure. You get enlargement of the right side when that happens as well. So there are many, many factors when we analyze whether someone has significant mitral regurgitation. And you can add exercise to that. One of the key things, I think we were doing supine bike when you were with us, at least I hope we were. Yeah. And we use the pulmonary pressure response to exercise. They may start out with a slightly elevated pulmonary pressure, but if they really have severe MR, mitral regurgitation, and they start to exercise, the pulmonary pressure becomes quickly hypertensive. So my approach is to do all of that. In other words, to do the volumes, to do the Doppler signals, to look at pulmonary pressure, the color flow signal, of course. So it's a multivariate kind of analysis. And I've left several things out. In fact, I had a paper that we wrote called, what was it? The 21 signs, or was it 24 signs of severe mitral regurgitation, 24 echo signs of severe mitral regurgitation. The 25th was jet area, and I called it 24 because jet area was such a poor sign. In fact, I think someone in your hometown there might have written that paper that talked about jet area, because that was the one thing you should never use.
Well, it can be so confusing because if your gains are too high, if you don't have the right the right transducer, your jet will be so big, it looks so big. You refer the patient for severe MR, and then you do the echo study, and it's actually maybe just mild or at most moderate. I mean, it is so
overdiagnosis. Now you've opened the door.
Yeah.
Overdiagnosis is a terrible problem. Terrible. People calling things that aren't there. Prolapse commonly, mitral regurgitation, aortic regurgitation. These things are really the bane of my existence. Getting patients who've been told they have a severe lesion when they don't, and this really is very disturbing to me, because all you have to do is think of the physiology of each of these things, and you kind of become close to what needs to be done. I mean, the difference is you're going to be all right, Mr. Jones, or you need to go to surgery. Now, that's a hell of a big difference.
Right.
And I think, as you well know in your long experience, sending someone to surgery is a big deal. Yeah. And we do that with great trepidation, and we were very careful about it, certainly, because you well know the consequences of the wrong decision in that regard.
What do you think about those? Because the patients also see their report, when they get the report of their echo
Well,
Doppler, they'll talk about the vena contracta, they talk about the PISA method, the Gerson volume. Do you use that?
you didn't mention the worst thing. The worst thing is the S word. You know what the S word is? Severe.
Oh, severe, right.
Some idiot writes down on an echo report, severe.
Right.
You have severe mitral regurgitation. I pull my hair out when they do that. We need a new word. I'd say the Z-score is 2. How's that? Instead of severe. But we got to stop using that word. That word causes us more trouble, more patient anguish. What does it mean? I have severe mitral regurgitation, doctor. No, you don't. But it says so right here.
Yeah, it's black and white.
Yeah, it's there. Yeah.
Well, I guess
do you use Apex in your practice?
The Apex.
Well, the electronic medical record.
No, we have some other one. We have Cerner, and we used to be on Epic, which was pretty good, but we have Cerner now,
Well, the patients are getting every single test result as they come on.
Exactly.
The S word is prevalent.
Right. Well, I guess for us, it's important to determine, when is it significant enough that we need maybe to take, some corrective measure, either fixing the valve or changing medication. But we've always worked on regurgitant volume, and regurgitant fraction. Do you think this is still kind of a good method to?
Sure.
How do you measure it?
It's okay. It's, effective regurgitant orifice is sort of the coin of the realm. We definitely calculate that, but of course, PISA is so irregular and difficult to deal with. It has to be just right. And of course, it usually isn't. So we get a number there that may or may not. But when they're at the extremes, there's no question about that. But of course, when they're at the extremes, you almost don't need it.
Right.
You can tell.
Right.
So we use it, but it's not. Believe me, I would not want a doctor to decide on whether I needed surgery based on an ERO only.
Right.
That would be something else.
You do planimeter the left ventricle and measure forward stroke volume in MR, or?
Oh, sure. That was that method we were working with years ago.
But with Steve Blum.
I will do that. And I'm looking forward to 3D because let me give you an example of why I know 3D is going to be dynamite. We have started doing 3D of the right ventricle in our research lab. 3D of the right ventricle. The volumes are identical to the left ventricle now. When we used to do them, they were tiny. And of course, they were wrong. There was no RV outflow tract included in the measurement. There was no way to measure the right ventricle properly. And now I know that that's going to work. So regurgitant volume will suddenly be in our labs. We'll be able to, with 3D, be able to really give people an exact, and in fact, what I would propose doing is once we have in our hand exact measurement, we would simply hand the patient a tennis ball and have them grip the tennis ball, raise their blood pressure, and measure it again accurately.
Yeah.
Measure it again accurately.
Do you feel the same about aortic insufficiency, Nelson, in the way of evaluating?
Aortic regurgitation is a big deal as well. And it's something you need to appreciate. One of the main things I see and errors I see are people not appreciating how important heart rate is in aortic regurgitation. For example, the slower your heart rate, beta blockers, for example, the slower your heart rate, the more regurgitation. And people with relatively mild regurgitation can be rendered quite incapacitated by having so much time in diastole for the regurgitation to occur. So using beta blockers or anything that slows the heart. I've had patients where their whole problem was their slow heart rate, which causes high blood pressure, by the way. If you have a slow enough heart rate, you'll clamp down, you'll get more backflow. And so the whole thing's a vicious cycle. All we had to do in one guy was put a pacemaker in, and the whole problem went away, and the AR became minimal. So, yeah, I'm very interested in aortic regurgitation, to be sure, and that's something I pay a lot of attention to.
What is the best Doppler technique that you rely on?
Well, I can tell you the worst one. The worst one is the pressure halftime, because that often just reflects high filling pressure. It has nothing to do with the volume of AR. The best thing that I use, and this may not meet universal agreement, is to look at the reverse flow in the descending aorta. Is to use a pulse wave Doppler in the. I learned that from Rick Nishimura, who did a quick study at Mayo, and I agree with him 100%. That is the ultimate way. If you measure, in fact, it was actually pioneered by a guy named Thierry Touche from France, who showed that you can, if you take into account the bulging of the aorta and the arch, because you have to do that as well, you can get forward and reverse flow with Doppler that way, and you can get a very accurate regurgitant fraction. Wow. So that's my favorite method.
Better than the width of the jet in the outflow tract.
Oh, well, the width of the jet is, I don't limit myself to one thing. I look at all.
Yeah.
But if you really asked me, you said, what's the best? You painted me in a corner there. And then you pulled the rug on.
It looks like I need to go back to the lab, maybe for a 1 month sabbatical.
I'd love it.
I would learn a lot.
When are you going to start?
Right, exactly right.
You're welcome anytime, Alain, anytime.
Nelson, why don't we
have a lot to learn from you. Yeah.
What about AI and Doppler? I mean, do you think there's what do you think?
Are you talking about artificial intelligence or regurgitation?
Right, exactly right. Good question.
So you must say AR, please.
AI or machine learning, artificial intelligence with valvular regurgitation. How do you think we can integrate intelligence?
Yeah, well, right now here, again, my sermon, I'll give my sermon. Right now, all our AR work, our AI work, artificial intelligence work, is directed at the old methods. We're trying to fix the old methods with this new tool. And so we really should be using it on 3D, not on the old analog methods. So having said that, there is really no terrific 3D for Doppler. There is actually where you could get the whole wavefront crossing in color, and then you could analyze, you could possibly do a 3D of that. I hadn't thought of that. Thank you for the idea. But Doppler will probably have to be analyzed the way we're trying to stuff 2D measurements into AI. So I'd like to see Doppler. Well, first of all, how many beats do we use whenever we make an assessment? Hardly any. We 2, 3, or we go for the maximum. But with AI, you could do 100 beats of something, and really get a number that would mean something. In other words, why we're throwing away all these beats? Are they no good? No, they vary because the heart varies. They vary because we breathe, we have inflow, outflow changes. The heart, I like to say the heart is a fractal geometrically, not Euclidean. And yet all our algorithms are Euclidean, right? They're based on a circle, a square, which is ridiculous. It doesn't work.
Not that way. Well, Nelson, I really enjoyed the discussion. about echo, the past, the present, and the future.
Yeah, it
looks
was
like
fun.
the
I
future
love
is very
talking
bright.
about this stuff. I love talking about this stuff.
Yeah,
And I'm glad you're still as interested as ever.
yeah.
That's
Well,
wonderful.
I mean, I'm following your lead, Nelson.
Oh, no.
Well, Nelson, professor of medicine at UCSF.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.